Speak about the nephritic syndrome. Nephritic means inflammatory process in which part glomerular basement membrane. Nephrotic means what? There is destruction of podocyte. Here there is destruction of what? Of the basement membrane, because it's a nephritic syndrome. So you must know the difference between infection associated glomerulonephritis, which means post-infectious glomerulonephritis, post-streptococcal glomerulonephritis, post-streptococcal glomerulonephritis, and what? An immunoglobulin A nephropathy, Berger disease. So here in post-streptococcal glomerulonephritis, it's 2 to 4 weeks after pharyngeal skin infection. But here in immunoglobulin A nephropathy, Berger disease, it's what? Concurrently. So 1 to 2 days after what? After respiratory or GI tract infection, or concurrently. So this is the main difference in the case scenario. So here, infection associated glomerulonephritis, post-streptococcal glomerulonephritis, post-infectious glomerulonephritis. It's what? Type 3 means what? Antigen antibody complexes, and there is deposition of this antigen antibody complexes, and it's associated with what? Hypocomplementemia due to consumption of the complement, leading to degrees C3 and C4. There is degrees in the complement due to consumption of it. Then there is a comparison between what? Between children and adults. So children mainly, it's what? It's because of group A beta streptococcus, post-streptococcal glomerulonephritis, but in adults it's mainly due to what? Staphylococcus. Also in addition to group A beta streptococcus, there is what? Staphylococcus. So it's caused also by what? By staphylococcus. Then the second difference here in children, it's group A beta streptococcus, so it's positive streptococcus serology. So positive serology, but here it's what? No serologic test available. So you will identify it on culture in adults. On culture there is no serologic markers, there is no serologic test available, but in children, group A beta streptococcus serology is positive streptococcus serology. In children usually resolve what? Spontaneously, but in adult it's what? It may progress to what? Renal insufficiency. Then what? Then here it's group A beta streptococcus 2 to 4 weeks after infection. But here in adults staphylococcus seen during infection, and infection site is variable, and usually not upper respiratory tract. So this is a comparison between children and adults. In children, group A beta streptococcus 2 to 4 weeks after infection, positive streptococcal serologies resolve spontaneously. In adults it's what? Group A beta streptococcus, but also by what? By staphylococcus. So you will get it, you will identify it on culture. No serologic test, and it's what? It's during infection. Infection site is variable, but it's usually not upper respiratory tract. Then what? In adult may progress to renal insufficiency. Then we will speak about LM, IF, EM. LM means what? Light microscopy. IF means what? Immunofluorescence. EM means what? Electron microscopy. So LM, light microscopy, glomeruli enlarged and hypercellular is the most important. It's asked in the exam. Group A beta streptococcus infection, group A beta streptococcus, group A beta streptococcal glomerulonephritis, post-streptococcal glomerulonephritis, hypercellularity. So here there is hypercellularity of the glomeruli. Then what? Then there is granular starry sky appearance, lumpy bumpy, granular starry sky appearance, group A beta streptococcal. So it's what? Granular. So on immunofluorescence there is what? Granular. granular. But on light microscopy, there is what post-streptococcal glomerulonephritis, there is what hypercellularity. Then there is what due to what deposition of immunoglobulin G, immunoglobulin M, C3 along the glomerular basement membrane and mesengium. So the most important here is what hypercellularity of post-streptococcal glomerulonephritis and granular pattern, lumpy bumpy appearance due to deposition of immunoglobulin G, immunoglobulin M and C3. Then what electron microscopy? It's subepithelial, and it's so important, and we will compare between other diseases and it after this infection. So there is what immunoglobulin A nephropathy. So on post-streptococcal glomerulonephritis, you must remember what hypercellularity, granular pattern due to deposition of these immunoglobulins, immunoglobulin G, immunoglobulin M, and subepithelial deposition, subepithelial hump. In immunoglobulin A nephropathy, Berger disease, it's what episodic hematuria, because it's a nephritic syndrome occurs concurrently or 1 to 2 days after respiratory or GI tract infection. It's due to immunoglobulin A deposition, because it's secreted from the mucosal lining. So immunoglobulin A secreted from the mucosal lining, and of course renal pathology of immunoglobulin A, vasculitis. HSB means what? Henoch-Schönlein berbera. So there is petechiae along the buttocks. It's associated with what? Immunoglobulin A nephropathy. So light microscopy, immunofluorescence, electron microscopy, there is what? Mesangial proliferation on immunoglobulin A nephropathy. And there is immunoglobulin A based immune complex deposition in the mesangium. And there is what? There is immune complex deposition mesangial on mesangial cells. There is what? On electron microscopy, there is mesangial immune complex deposition. So immune complex deposition on the mesangium, and there is what? There is proliferation of mesangial cells. So immunoglobulin A nephropathy, Berger disease, it's what? Mesangium. Light microscopy, mesangial proliferation. Immunofluorescence, immunoglobulin A based immune complex deposition in mesangium. Electron microscopy, mesangial immune complex deposition. Then the next one, there is what? Rapidly progressive crescentic glomerulonephritis. What's meant by rapidly progressive crescentic glomerulonephritis? It has poor prognosis and rapidly deteriorating renal function days to weeks. So there are many diseases that will end by what? Rapidly progressive crescentic glomerulonephritis. So we have on light microscopy, this is the most important, crescent moon shape. So this is the crescent moon shape. This is the crescent moon shape. So it's a rapidly progressive glomerulonephritis. So crescents consists of what? Fibrin. It's asked in the exam. Fibrin. So the crescent from what? Fibrin. And there is also what? Plasma protein C3b with what? Glomerular parietal cells, monocytes, and macrophage. But it's what? Fibrin. So rapidly progressive glomerulonephritis, crescentic glomerulonephritis, it's what? On light microscopy, there is crescent moon shape, and we saw it. Crescent moon shape consists of what? Fibrin deposition. Then several disease will end with what? Will end with rapidly progressive glomerulonephritis. Result in this pattern, which is rapidly progressive glomerulonephritis. Its appearance on what immunofluorescence. So there is what granular and linear, and there is negative immunofluorescence. So as a granular pattern, in which disease? Post streptococcal glomerulonephritis, diffuse proliferative glomerulonephritis. So what are these two diseases? So post streptococcal glomerulonephritis, diffuse proliferative glomerulonephritis, these are the two diseases for what? Nephrotic syndrome, post streptococcal glomerulonephritis, and diffuse proliferative glomerulonephritis, nephrotic syndrome. So it's what? It's a granular pattern. Then we have the linear immunofluorescence. Means what? Means it's type 2. What is the difference between type 2 and type 3? Type 2 means antibodies against the glomerular basement membrane or the alveolar basement membrane. So antibodies against antibodies will go and attack, but in type 3 means what? Means the antigen antibody complex, and then they will go with each other to cause deposition on the tissue. But in type 2 means what? Type 2, the antibody will go and attack antigen in its site. So antibody will go and attack what? Glomerular basement membrane and alveolar basement membrane in case of what? Goodbusher syndrome. So Goodbusher syndrome, suffering from what? Suffering from hematuria, hemoptysis. Why hemoptysis? Because there is attack from antibodies against what? Alveolar basement membrane. Hematuria. Why? Because there is attack from antibodies against glomerular basement membrane. So here Goodbusher syndrome means what? There is attack of antibodies against the basement membrane in glomeruli leading to hematuria, and in alveoli lung leading to hemoptysis. So the treatment is what? Plasmapheresis, and then there is the last one, which is what? Negative immunofluorescence. It's called Bussy immune. So there is no immunoglobulin C3 deposition. No. Why? Because it's a Bussy immune. Means what? Negative immunofluorescence. So we have to differentiate between two diseases, which is what? Granulomatosis with polyangiitis, and again granulomatosis with polyangiitis, but there is add-on of what? Eosinophilic before it. So granulomatosis with polyangiitis called what? Wegener syndrome. Wegener. So it's what? BR3 ANCA or C ANCA. So C ANCA is Wegener granulomatosis with polyangiitis without eosinophil. But here granulomatosis with polyangiitis and eosinophilic. So it's called eosinophilic granulomatosis with polyangiitis. It has another name called what? Microscopic polyangiitis, and it's what? MBO ANCA and B ANCA. What is the most important here? To remember which one C ANCA, which one B ANCA, which one C ANCA and which one B ANCA. So C ANCA, Wegener granulomatosis with polyangiitis. B ANCA eosinophilic granulomatosis with polyangiitis, or microscopic polyangiitis. So then in the exam he will ask you about finding of what? Neutrophil. Then you will ask me, where is neutrophil here? ANCA. C ANCA and B ANCA. ANCA means what? Anti-neutrophilic cytoplasmic antibody. ANCA means what? Anti-neutrophilic cytoplasmic antibody. So it's called what? Anti-neutrophilic. So there is what? Neutrophil in these diseases. Granulomatosis with polyangiitis called Wegener, it's B ANCA. So there is what? Against the neutrophil. C cytoplasmic. C means cytoplasmic, and B means perinuclear, surrounding the nuclei. So it's what? Eosinophilic granulomatosis with polyangiitis, microscopic polyangiitis. It's what? B ANCA. Then the next one, it's called what? Diffuse proliferative glomerulonephritis. So we have diffuse proliferative glomerulonephritis and we have membranoproliferative glomerulonephritis. So diffuse proliferative and membranoproliferative. Both of them is what? Nephrotic plus nephritic. Nephritic. So there is what? Diffuse proliferative glomerulonephritis. It's what? Systemic lupus erythematosus. Wire lupus. So light microscope is the most important here. Wire lupin. So where is the wire lupin? This is the wire lupin. This is the wire lupin. Diffuse proliferative glomerulonephritis. Wire lupin. Then the next one, we will speak about what is the immunofluorescence, granular. We spoke about it. Diffuse proliferative glomerulonephritis, granular. Electron microscope, it's what? Subendothelial, and you must know this. So the most important is what? The wire lupin plus subendothelial. Why? Because here in post-streptococcal glomerulonephritis, it was what? Subepithelial. But here in diffuse proliferative glomerulonephritis, it's what? Subendothelial. And of course, membranoproliferative glomerulonephritis, it's also subendothelial. So diffuse proliferative glomerulonephritis, membranoproliferative glomerulonephritis, nephritic and nephrotic. Both of them subendothelial. Sometimes subepithelial intra membranous immunoglobulin G based immunofluorescence. It's what? Granular. Sometimes the subepithelial intramembranous immunoglobulin G based immune complex with what? With C3 deposition. So light microscope is what? Wire lupin. Immunofluorescence is what? Granular. Electron microscope subendothelial is so important. Sometimes the subepithelial intramembranous immunoglobulin G based immune complex with what? C3 deposition. But the most important is what? Wire lupin plus subendothelial.